Good afternoon, everybody. Welcome to this clinical pathological conference. This is the last CPC of this session. So today we are going to discuss a very interesting case. To discuss the clinical parameters, we have today Professor Narayan Prasad. Professor Narayan Prasad is head of the Department of Nephrology. The long list of attached to his sir is the Honorary Secretary of Indian Society of Nephrology, Deputy Chair of South Asian Board, International Society of Nephrology, Counselor, Indian Society of Nephrology, member of Pradhan Mantri National Dialysis Program, Global Burden Disease, lots of publication, more than 250 publications, 23 chapters. So I request sir, please come and discuss the clinical.
At the outset, I would like to thank Dr. Arvind Bakasher, Dr. Aditi, Dr. Pankaj Hari, all the faculty members of the faculty of Nephrology, Professor Sanjay and our colleagues in the Department of Nephrology for this opportunity to be here and to discuss such an important case. When I have reviewed the literature, I have gone through so many reviews across, and this was very much informative. Learned a lot from this kind of discussion. So, just to brief out the case details are there with you. This was a 16-year-old boy who born on July 2005 from the Jaipur, Rajasthan, and the history was given by father that was very reliable. And I would like to have your attention here that the patients, after 2 years of the birth in 2007 to 2005, the patient had nephrotic syndrome, childhood nephrotic syndrome, and the patient has been treated with very standard treatment of the 6 weeks of the daily regimes, followed by 6 weeks of the alternate day regimes, and patient went into remission. Then here we can see, we like to draw your attention. This was the long history up to the 2022, but I would like to congratulate the pupils who have made this diagram to summarize this 13 years of the history in one diagram here. So then the patient had steroid dependent course, and the patient has been treated subsequently the oral cyclophosphamide first, then mycophenolate mofetil. Here you can see as the steroid was being tapered, the patient used to have relapse, and they used to give add-on therapy, steroid sparing regimes, mycophenolate mofetil, and subsequently it was treated by rituximab, that was the 5 doses given, and then followed by mycophenolate mofetil. So mycophenolate mofetil was given almost for 46 months altogether, and 5 doses of rituximab. So very difficult to treat steroid dependent nephrotic syndrome. And 2012 the patient has all kind of this toxicity of the steroid, causing white faces, obesity, hypertension, cataract. So that was all expected with this much of the dosage of the steroid. So when we look at the picture of the course of the steroid sensitive nephrotic syndrome, we see here steroid sensitive nephrotic syndrome, 25% patients need to take this steroid dependent course. And should this patient, one of the very important questions comes in the mind that is very controversial in the day-to-day practice, whether this patient should have been biopsied before rituximab. It is possible, might have, but this was not in the clinical discussion portions which I have been given. So this patient, the similar kind of the treatment, many times FSGS or membranous patient also responds to corticosteroid, mycophenolate mofetil, cyclophosphamide, and rituximab. This kind of the combination of the treatments, some of the patient also responds. They're not moving. So now the questions comes. Really, in practice, day-to-day practice, we used to treat these patients with the empiric therapy with the prednisone, 6 weeks followed by 6 weeks. And if the patient falls between the age of the 1 to 10 years, no hypertension, gross hematuria, patient had normal serum creatinine, normal complement level, no extrarenal symptoms, then definitely empiric therapy is the choice. But those who do not meet the criteria, kidney biopsy are usually done. Steroid assistant nephrotic syndrome is a definite indication, but steroid-dependent course, particularly the difficult to treat patients, threshold varies from center to center of getting the biopsy done. So difficult to treat patient can be biopsy. So I would like to have your attention here in March 2018, when the patient in 2013 treated with rituximab. After that, the patient was in remission for 4-5 years. There was no relapse, no anything related to nephrotic syndrome. Here in March 2018, the patient had fever and some nodal lumps appeared in the neck and axilla. And that lumps was firm, painless, no signs of inflammation. The most important point to be noted here is the spontaneous remission. Why the patient went into a spontaneous remission. And this happens at some other centers in Jaipur. After 2 years of this, here we can see in January 2020, patient had again the reappearance of the swelling. And this time it was very clear that probably it was looking like some of the lymph nodes which appeared enlarged. So what we can see here, this time the patient has been evaluated. I will discuss a little bit some of the biochemical investigations later on. But again, after about 1 year, patient has been 6 months treated. At this point of the time in January 2020, this patient has been given with some treatment of the 6-month course plus IVIG every 4 to 12 weeks for 2 years. This patient is continued on that. So that is very remarkable point. Here we can see why this patient was getting this intermittent IVIG and 6-month course. The details of the treatment has not been given to me, so I am not able to discuss, but I will guess what is there. So in November 2021, about 9 months or 10 months after that 2020 episodes, the patient has again the recurrence of this nodular swelling in the both side of the neck. And presently it was for the 2 weeks. There is this progressive increase in the number and size, low-grade intermittent fever, responsive to paracetamol. Here you can see there was no history of the B symptoms and no other significant history of the upper respiratory tract or GI infections, no history of the swelling of the face, hoarseness of the voice, no history of contact to a patient with active TB, no contact to the any pet animals. So looking at the birth and development history, this is not too much contributory. Some side effects you can see of the steroid, so little bit less growth than expected. Family history, again, that is one remarkable thing. The child's father has extensive acrofacial vitiligo and mother has bronchial asthma. And 2 paternal aunts and the maternal grandmother has hypothyroidism. So that is another important clinical clue here. There was some history of this, some autoimmune disease in the family was going on. So on clinical examination this time, the child was conscious, cooperative, comfortable. Cardiac examination and general examination was almost normal. BMI was also acceptable, just minus 1.9 standard deviation below the expected, and sexual maturity was also rated fine. So on clinical examination here, when the examination of the lymph node was enlarged, bilateral in both sides of the neck, anterior and posterior cervical chains were enlarged. Lymph nodes were submandibular and bilateral posterior cervical lymph nodes were also enlarged. The character of the lymph node was it was non-mobile, non-tender, non-matted, and soft to firm in consistency. And there was no changes on the skin over these lymph nodes. So that and other like oropharynx and other tonsils were normal here. Systemic examination was not contributory, except there was some little large liver of the 1 centimeter below the costal margin. So looking at this investigation chart which has been given to me, here we can see at 2 points of the time. Here there was a little lymphocytosis here, because this is more than 40%. Here again lymphocytosis is there. This is the course during the nephrotic syndrome treatment. Here we can see, and the patient looks like in the remission. Here you can see the remission, remitting and relapsing course as look like the steroid dependent course. and other parameters like the cholesterol, and these were all suggestive of the classical childhood nephrotic syndrome. So here to point out, most of the times, almost 50% of the children who relapse with the nephrotic syndrome almost had upper respiratory tract infection happens off and on. So it is possible on the background of this lymphadenopathy, whether the patient was suffering from some other basic disease, might be immunodeficiency syndrome. So now coming to this part, here we can see this patient has nothing in 2018. Here in 2020 January, this patient had anemia that was macrocytic hypokalemic anemia, and that has been treated and the patient improved. What is the remarkable point? The patient had low immunoglobulins levels throughout. So hypogammaglobulinemia was there, including both IgG, IgM, and IgA. So for that age group, this was definitely very low. So that was the one important point. And looking at the nephrotic syndrome part, the patient was totally in remission. And there was no eosinophilia. What we can see, only one point of the time here, we can see a little bit of more of lymphocytosis was there here, and 42% here in January 2022. This X-ray is a non-contributory. I don't think there is any change. This looks like normal in 2018 and 2020. Also, this X-ray was normal. In 2021, there was some little increased bronchovascular marking there. That is might be some little variation of the exposure that looks like, or it is possible that some underlying other organ involvement could be there. So our radiology colleague and pathology colleague will discuss about your other diagnostic tests. I am coming to our clinical discussion part. So when we look at the highlight of the case on the background of the steroid-sensitive nephrotic syndrome and steroid-dependent course, patient has been treated with the cyclophosphamide, mycophenolate mofetil, and rituximab. 3 episodes of the fever with lymphadenopathy, a strong family history of the autoimmune disorder, 6-month treatment course. Here comes the clue. What was the 6 months of the course with this enlarged lymph node? That is possibly as might be the tuberculosis, anti-tuberculosis therapy has been given, and possibly it is on the background of the immunodeficiency. It is looking like it might be the lymphoma also. ABVD regimes has been given for the Hodgkin's lymphoma, and IV infusions was given 3 to 4 monthly. So hypogammaglobulinemia was definitely there. That has been well documented. And there was 1 episode of the macrocytic hypochromic anemia. So here comes a situation where the fever with lymphadenopathy, we can think of whether this was infection, autoimmune disease, or it was malignancy. Infection, it is possible the patient has received a lot of immunosuppression, hypogammaglobulinemia there. Autoimmune, a strong family history of autoimmune disorders, hypogammaglobulinemia, and we can think of very common variable immunodeficiency syndrome would be the possibility at this age. And malignancy, definitely the way the patient has been given the 6 months of the therapy, and it is possible that with a lot of immunosuppression that impair the cancer surveillance and facilitate the oncogenic potential of the many of the viruses like Epstein-Barr virus. So it is possible that the patient had developed malignancy associated with some of the activation of the viral infection. But this patient was negative for all the workup for the Epstein-Barr virus, cytomegalovirus infection. By even this patient has been tested for the tuberculosis. Gene expert was negative. So all these things was going against the infection episodes. Can we have a button here? So coming to some important differential diagnosis here, what we can think of the tuberculosis, infectious mononucleosis, lymphoma, some Kikuchi disease, and some autoimmune lymphoproliferative disorders. Infectious mononucleosis syndrome is looking like unlikely because of the Epstein-Barr virus serology was negative and no other clues for the CMV and toxoplasma infection were there. I will take one by one. Acute infectious mononucleosis usually characterized by the triads of the pharyngitis, cervical lymphadenopathy, and fever, and begins to rise in adolescent and declines through adulthood. presence of lymphocytosis that we have witnessed. A spontaneous remission was common because this patient had the first time a spontaneous remission. So that was looking like something else was there at that point of the time, whether this was the infectious mononucleosis. May recur after months or years, but all points were there. The patient might have the atypical lymphocytes and confirmatory serology was not reported here. Maybe biopsy to rule out the lymphoma. Epstein-Barr virus was negative. That was the strongest point. And nephrotic syndrome is rarely reported, at least not before the onset of this lymph node enlargement and this kind of lymphadenopathy. And hypogamma is also not seen in this patient. But this patient prone to develop Hodgkin's lymphoma in future. Other important differential diagnosis that comes in the mind was the Temura disease. It's Kikuchi disease. Here we can see lymphadenopathy is seen in 100% of the patient, usually tender, but these patients have the non-tender lymph nodes. Fever is seen in 35% of the patient. Self-limiting course responds to steroid, but may have recurrence in up to 11%. So this patient has a spontaneous remission, and recurrence happens 3 times. So it is looking like, and it is common in the Asians and reported in all races. And in children, it can be seen more in the male, but otherwise it is more common in female. But all point was there, hypogamma and 6 months of the therapy, because this disease is self-limiting, usually it is not given. So it does not look like the condition. Temura disease, again, it is very common, usually associated with this lymphadenopathy, regional lymphadenopathy and cutaneous mass, but self-limiting course and response to steroid that goes in favor. But again, the very odd point is there, blood and tissue eosinophilia and was not there. Eosinophilia was never noted, and markedly elevated serum immunoglobulin key levels are seen. That has not been reported. So that was very odd against this year. But usually, what we see, the many case reports of the nephrotic syndrome associated with Temura disease is there, but none of the, almost all reports are there associated with the active disease, not before, like happened in this patient. So it is again against this Temura disease. ALS, autoimmune lymphoproliferative syndrome, again characterized by lymphadenopathy, autoimmune hepatitis, glomerulonephritis, and uveitis can be seen. Lymphoma may develop, but several odd points. Most of the times, this patient has autoimmune hemolytic anemia, thrombocytopenia, and leukopenia is there. Splenomegaly was not seen in this patient. Usually, there is hypergamma here. It was in contrast, there was hypogamma. So it was also not looking at the possibility. So differential diagnosis of hypogamma, which was a very prominent thing in this case record. So here we can see in genetic disorders, you might have the X-linked hypogamma or common variable immunodeficiency syndrome. These are the 2 differential diagnoses I want to discuss. And drug-induced. Patient have received a lot of glucocorticoids, and the patient was on the background of the nephrotic syndrome and received rituximab. And malignancy, Hodgkin's and non-Hodgkin's lymphoma can be there. And systemic disorders, nephrotic syndrome was there, but at this point of the time when the patient developed hypogamma, the patient was in remission, not with the active nephrotic syndrome. So X-linked hypogamma, why I thought of, because this was, patient was boy, 16-year boy, and X-linked was there, so usually it happens in the boy, male boy. So here hypogamma with low B lymphocyte count are usually seen, but usually it is characterized by mutation noted in the BTK genes, Bruton tyrosine kinase genes, and failure of the maturation of the pre-B cells to the mature B cells are usually failure. So absence of the peripheral B lymphocyte and reduced number of the serum immunoglobulins, hypogamma can be seen here, that was there, but recurrent and severe bacterial infections. Usually cases of the nephrotic syndromes and have been reported, 2 cases of MPGN, 1 cases of MGN has been reported, but these patients are usually have recurrent respiratory tract infection, chronic lung disease by the time they should develop. That was not there, and usually it develops early, then common variable immunodeficiency syndrome. X-linked lymphoproliferative syndrome, again, we thought because this was the boy. So again, X-linked, this is it. But usually this happens on the background of the active Epstein-Barr virus infection. And this patient's workup has shown the patient was negative for Epstein-Barr virus infection. So it is also not looking like the possibility. The important possibility which I want to discuss here was the common variable immunodeficiency syndrome. It is defined by usually all, including IgG, IgM or IgA, all should be below, and that was far low. Almost negligible amount was there of the IgA. At least two, it should be at least 2 standard deviation below mean for the A. But in practice, we should exclude other causes of the immunodeficiency syndrome also. So common variable immunodeficiency syndrome had two different kind of the presentation. And usually what happens in one kind of the disease, when memory cell is also depleted, predominant manifestations comes as a autoimmunity in common variable immunodeficiency syndrome. When you have only limited less number of the B cells, then it is possible that in that scenario, in phenotypic variations, you might have the manifestations of the lymphadenopathy, infection and lymphoma, which can be seen in 8.2% of the patients, and hallmark is usually relative or complete loss of the plasma cells in the bone marrow in day-to-day practice, which we can get it done even at remote places. So there are multiple pathogenesis of developing lymphoproliferative disorders in patients of the common variable immunodeficiency syndrome. That might be the infection, radiosensitivity, T cell abnormalities. So there are possibilities that this patient had on the background common variable immunodeficiency syndrome and developing recurrent lymphadenopathy. So what was the possible reason of this child being treated with the IVIG infusion? On the background, what we can see, autoimmune disease in the family, childhood nephrotic syndrome, recurrent lymphadenopathy, 6-month course, probably what I guess, probably ABD regimen of the lymphoma, hypogamma globulinemia, and periodic treatment with intravenous immunoglobulins was given. So lymphoma and nephrotic syndrome, here I would like to have your attention. Nephrotic syndrome can happen as a paraneoplastic manifestations of lymphoma, and many of the lymphoproliferative disorders, leukemia, Hodgkin's or non-Hodgkin's lymphoma, and nephrotic syndrome in Hodgkin's lymphoma has been reported in different registry, 1% or 0.6%, and nephrotic syndrome can develop before, after, or simultaneously. So lymphoma and nephrotic syndrome, 38% of the patient develop nephrotic syndrome before diagnosis of lymphoma, 43% develops after, and 19% develop almost simultaneously. So gap between the nephrotic syndrome and lymphoma has been reported up to 42 months. Here in this case, it appears up to 5 years. So it is possibly might be the paraneoplastic manifestation. So when look at that series which has been published here, even nephrotic syndrome or minimal change disease associated with the lymphoma can have the remission in 72% of the patient, can be resistant in 16%, or can be dependent course of in 11% of the patient. So, and common variable immunodeficiency syndrome can have lymphoma in one of the studies as shown in 11.1% of the patients. Recently, just 2 years before, there was one publication came in Kidney 360, and they have evaluated all their cases of common variable immunodeficiency syndrome. They found out of probably 400 cases of the common variable immunodeficiency syndrome, 22 cases of nephrotic syndrome, 12 of them have immune complex glomerulonephritis, and 9, approximately 40% patient had the membranous glomerulonephritis. So it is possible that this patient of the common variable immunodeficiency syndrome can have this kind of the manifestations. Other important that looks very straight, the patient has been given heavily immunosuppressed with steroids and rituximab. So whether this was the hypogamma globulinemia after rituximab, B cell reconstitution is variable after administration of rituximab. So one of the series has shown that probably even 50% of the patient in granulomatous polyangiitis patient, when they have tried to give this rituximab, they were already had low immunoglobulins. And when they gives it, this go further down. So it is possible that hypogammaglobulinemia has been aggravated after use of the rituximab. So hypogammaglobulinemia after rituximab, currently there is no evidence that pan-hypogammaglobulinemia is related to the cumulative dose. It may be independent of even the single dose or 2 doses can develop pan-hypogammaglobulinemia. Prior exposure to cyclophosphamide, as this patient had received cyclophosphamide, may increase the risk of the pan-hypogammaglobulinemia. Less than 5% of the patient may acquire intravenous immunoglobulin replacement to reduce the infection rate. And reconstitution of the immunoglobulins has been reported in one of the series out of the 12. 2 patients, one patient took 4 years and another patient took 7.5 years to get this reconstitution. So hypogammaglobulinemia and rituximab can be one of the possibility. So summarizing the clinical clue for the final diagnosis: background of autoimmune disease in the family, history of the childhood nephrotic syndrome, recurrent lymphadenopathy, treatment history of the 6-month hypogammaglobulinemia, and periodic treatment with the intravenous immunoglobulins. What we see in our final diagnosis, what I guess, by the common variable immunodeficiency syndrome. Patients had associated lymphoproliferative disorders that turned out to be Hodgkin's lymphoma, and nephrotic syndrome was the manifestations of the paraneoplastic manifestations before Hodgkin's lymphoma, and maybe membranous versus minimal change disease. And other differential diagnosis is steroid-dependent nephrotic syndrome, rituximab-induced hypogammaglobulinemia, infection, associated lymphadenopathy or other viral lymphadenopathy could be there. Tuberculosis looking less likely, although it is very common. We should always keep in differential diagnosis in countries where we are working, but it is looking unlikely because this patient has been worked out for the tuberculosis and gene expert test was negative. So that's all. Thank you, ladies and gentlemen. Thank you for your attention.
Thank you, sir. Very briefly, nicely discussing all the possibilities from clinical point of view. I like to ask the audience for any questions or any possibilities.
Does spontaneous remission make any spontaneous remission the rating? Does it make any change in your diagnosis?
Sir, I thought of that, but what is there when we go through the literature of the common variable immunodeficiency syndrome? This depending upon they might have the recurrent episodes of this. So as this was a spontaneous remission and there was a recurrence also, so that's why we have discussed the two important possibilities. That was the Kikuchi disease and Temura disease. There it happens very commonly. Lymphadenopathy, fever, they respond to the small dosage of the steroids also. So, but other features were not in that favor. So that was the one part. A spontaneous remission happens once, and that has been treated outside at Jaipur. There were no details given into that, whether this patient has been treated. But the only thing everywhere it was written that a patient has been treated with paracetamol and the fever was responsive to paracetamol. So that looks like some of the common viral infections coming again and again and causing activation and causing this lymphadenopathy. It is common possibility that I feel. So that was all about this spontaneous remission of this.
The initial episode of Nephrotic syndrome was
yeah, so that was my guess, sir. That was a total paraneoplastic syndrome, what I think, because I have gone through the literature and seen that there was a report, the largest gap between before when this nephrotic syndrome happens and lymphoma happens was 42 months. Here it looking like little more, but it is possible that it is known that in childhood Hodgkin's lymphoma paraneoplastic manifestations happen. So that is the guess, but everything in today's practice, I think everything is dependent on the investigations. If you have the big lymph nodes, you can just go through the true cut biopsy and you can see this histology and you can clinch the diagnosis. Even the CT report has not been given to me, but having the CT report, when you see there is a necrotic patches within the lymph nodes, you can think of it is infected. When there is no necrotic passage, generalized enlargement. you think of something malignancy. So there are so many clues now comes in, but definitely for clinical discussion, this was very interesting for me to learn so many things when we are going through this rare case.
You are making comparing lymphoma and nephrotic syndrome. If we take these two, then paraneoplastic is far less common as long-term immunity.
I agree, sir. But what happens? There was a little, very much gap with this the onset of the nephrotic syndrome, then developing lymphoma. Concomitant was seen only in 19% of the patients. So paraneoplastic manifestations in 38% of the patients in the biggest studies published, as shown, probably 38% pre, 43% after, and only 19% simultaneously.
No, I'm saying if we take these two as a population, these patients have got a very long-term history of immunosuppression. If we compare, say, in a transplant patient, then the lymphoma from that angle is far more common. In point that, would you like to see some fiction for the etiology of lymphoma in terms of the biopsy, whether you want to see any specific pattern of histology for square?
Sir,
Or just leave it.
sir, our threshold is very low for doing the biopsy. Most of the times when I used to do biopsy, then send to sir. For many times, a difficult patient. But definitely, this patient was the candidate, and the way the patient was difficult to treat steroid-dependent nephrotic syndrome. It was not the normal steroid-dependent nephrotic syndrome having a response on this low dose. So, given 5 doses of the rituximab, treated for the 47 months of this mycoplasma of tails. So definitely heavy immunosuppression was there. Heavy immunosuppression can predispose malignancy, can activate malignancy, because there are two important reasons. One is that whatever there is the immunogenic mechanism to prevent the development of lymphoma, so that to go off with this immunosuppression. So that is the one important point. Overall immunosuppression we understand from this transplant practice that they are responsible for developing lymphoma. But here pan-hypogammaglobulinemia was the catch point. So this pan-hypogammaglobulinemia happens only after giving this rituximab, before it was normal, or this happens because there was no previous report. So pan-hypogammaglobulinemia, and that is far more common in common variable immunodeficiency syndrome than patient developing only with the rituximab therapy. So that was my reason. I thought of this patient might have common variable immunodeficiency syndrome, and possibly if we could have biopsy, it might be the membranous rather than typical minimal sensitivity. Because that series is showing more of common variable immunodeficiency syndrome, 40% patient having the membranous rather than MCD.
If you have this kind of a treatment scenario, which one you prefer?
Yeah, definitely. Kidney biopsy happened in this patient was far before. So here, when you have the EG to see the glands, definitely I will go for the gland biopsy first to come on the diagnosis. Kidney biopsy is usually a relatively more invasive procedure than your lymph node biopsy or FNSC of the lymph node. So definitely we will keep it back. But in this patient, this was the difficult to treat steroid-dependent nephrotic syndrome almost 2012. This was the end point of the nephrotic syndrome. After that, that patient remained in sustained remission up to 2018. Still, the patient is in remission. So that is not a problem here. Problem is here, what was the reason of this recurrent lymphadenopathy? Not of the pure nephrology case, but definitely of the interest.
There's nothing related or non-mentally important syndrome. The course is usual to see. I think it is a usually important syndrome. And something happening on top of it.
Thank you.
Any other questions? So system starts, we have some time for this question. There's some system needs.
Hey.
And in absence of that, probably CKD is something which comes to mind that not there. And the second thing is that the diagnosis. In terms of that, we need to know what is the cause, and we can really even that affects one of the things which is there. So this was also coming to my mind. And second, a recent thought was regarding the presence of lymphadenopathy setting in presence of so many immunosuppressions. Are we sorry if I just look at the area of this? Okay, fine. Yeah.
Actually, coming to your point, common variable immunodeficiency syndrome usually presents little late, and it can be seen even some people have been detected at the age of the 60s or even older patients. So it is not that malignant like your A gamma globulinemia